already covered. Okay, so this little cartoon is about our patients, and I think it's important to remind them in one way or another that medicines don't teach skills, and that's where therapy becomes critical. Our medicines are only going to do so much, and they will treat the underlying neurobiology, but they won't treat the environmental stressors or poor social skills or communication problems. And so it's important to recommend therapy as well as getting people on the right medication. So this is a review of the neurotransmitters and the receptors. The icon on the left is showing us our three major neurotransmitters that we know are involved in depression, the norepinephrine, serotonin, and dopamine, and how, although they do have some individual characteristics, there is a great deal of overlap as well. The icon on the right side is reviewing neurotransmission. We have a presynaptic neuron, the synaptic cleft, and the postsynaptic neuron. And we see the vesicles that contain the neurotransmitters that will be released into the synaptic cleft and will bind to the receptor sites. And we learned about norepinephrine as well as dopamine. Now we also have theories of glutamate and inflammation, which gives us a whole nother view of the neuropathology of depression. More recently, the use of a glutamate antagonist, ketamine, at the NMDA receptor has actually now been released for treatment-resistant depression. And this slide is reminding us where the neurotransmitter is produced and what the precursor amino acid is. So 5-HT is from the raphe nucleus. It is produced by the precursor tryptophan. The catalytic enzyme is the MAO-A or B. Dopamine is produced in the substantia nigra, and the precursor is tyrosine. And again, the catalytic enzyme is MAO-A or B or COMT. Norepinephrine is produced in the locus ceruleus. The precursor is the tyrosine. And again, the catalytic enzymes include MAO-A, B, and COMT. Those are the three you must know. You will be tested on those. 5-HT, we know that about 90% is actually synthesized in the lining of the gut. And we also know there are about 600 million bacteria in the gut, and potentially they could be influencing mood. There are 100 billion neurons. Each has greater than 10,000 possible connections to other neurons. And we have hundreds of different receptors on each. So potentially we have trillions of synaptic activities occurring in 1/1000th of a second. The first 5 categories here are geographical, and they refer to where the receptor is found on the neuron. So we have presynaptic autoreceptors, dendrosomatic, axonal somatic, presynaptic, and the postsynaptic. The two most important areas for our psychiatric medications are the presynaptic autoreceptors and the postsynaptic. Then the two categories on the bottom, ionotropic and metabotropic, refer to how quickly the receptor responds to the neurotransmitter. Ionotropic tends to be quick, and metabotropic is much slower. NEIglobal.com is an excellent resource. It's about $250 annually. There is a reduced cost for students. There is also a master psychopharmacology course. You have up to 1 year to complete it, and a final exam of 100 questions. Many of the test yourself questions are from the Dr. Stahl resources on NEI. So the brain regions involved in depression are pretty much all of them. We've listed the most important areas on this slide. From top to bottom, the frontal cortex, including the PFC, the DLPFC, the OFC, and the VMPFC, the anterior cingulate cortex, as well as the limbic system and the brainstem. Remember all the parts of the brain, if that's helpful for you. Just to say an additional word about the previous slide, what we want you to do is match the symptoms of depression to the circuits. We know that in depression that there are alterations in neuronal activity and alterations in the efficiency of information processing. And this occurs in all of the brain regions mentioned on the previous slide. Alterations in each of those brain regions can lead to symptoms of a depressive episode. Okay, now we're going to talk about theories of the psychopathology of depression. And I went too fast past the slide, and I think I might have missed something. I did not. Okay, let's get into the three major theories of depression. The first one is the monoamine theory. In this theory, there is a deficiency of neurotransmitters, and the medications block the reuptake of the neurotransmitter from the synapse, and that results in relief from depression. The second theory is the neuroreceptor theory. Neurotransmitters are low, and so the receptors have upregulated. By blocking the reuptake of the neurotransmitter from the synapse, there are more neurotransmitters, and so the receptors downregulate. This promotes shifting and better functioning of the neuronal system, and the patient gets better and the depression is alleviated. The neurogenesis stress diathesis theory focuses on the combination of genetics and epigenetics disrupting the neuronal system. In this case, the BDNF is deficient and also compromises the neuronal system. Medications initiate the process of the signal cascades downstream that increase BDNF, and that results in strengthening the neuronal system. Okay, this slide is looking at the time course of antidepressant effects There are three effects. There are clinical changes, there are neurotransmitter changes, and there are receptor sensitivity changes. Here we see an antidepressant is introduced, and the amount of neurotransmitter will change rapidly after the medication is started. However, the clinical effect is delayed, and in addition, the desensitization or downregulation of the neurotransmitters is also delayed. The hypothesis is that changes in the neurotransmitter receptor sensitivity may actually mediate the chemical effects of the medication. Review of the monoamine hypothesis of depression. The classic hypothesis: when there is a normal amount of neurotransmitter activity, there is no depression. In this hypothesis, the activity of the neurotransmitter is deficient, and this results in upregulation of the postsynaptic neurotransmitter receptors, thus resulting in depression. Okay. So this slide, labeled SSRI, this icon is to depict the core feature of SSRIs, which is serotonin reuptake inhibition, also known as SERT, serotonin transporter inhibition. SSRI inserts itself into the serotonin reuptake pump, or the serotonin transporter, also known as SERT, and blocks it. In doing so, it causes an antidepressant effect. Okay, here we see a depressed person. We see 5-HT being low, and the person is in a depressed state with upregulated receptors, and there's a low number of signals in the neuron available to release more 5-HT. And then we're going to slide. An SSRI is taken, blocking the SERT, the serotonin transporter, and this causes the serotonin to increase, but initially it increases only in the somatodendritic area, or the serotonin neuron, which we see on the left with the red circle. But at this point, there's still not very much in the axon terminals on the right. The increased serotonin at the somatodendritic area of the 5-HT neuron results in desensitization or downregulation of the autoreceptors. And you see the red circle. Once the somatodendritic receptors downregulate, there's no longer inhibition of the impulse flow in the serotonin neuron, and so this results in turning on the impulse. There we go. This will result in release of 5-HT in the axon terminal. Again, we have a red circle there. However, this increase is delayed due to the time it takes for the somatodendritic 5-HT to downregulate the 5-HT autoreceptors and turn on the neuronal impulse flow. This is why the meds do not relieve the depression immediately. So to summarize, first, the SSRI medication blocks the reuptake pump on the SERT. And number two, the serotonin at the somatodendritic area increases. Thirdly, the somatodendritic autoreceptors become desensitized. And four, the neuronal impulse flow is turned on, and there is an increased release of 5-HT from the axon terminals. The final step is the desensitization of the postsynaptic 5-HT receptors. Okay, this slide, the monoamine hypothesis of antidepressant action on gene expression. We see the neurotransmitter at the top is increased by medication. This results in changing the expression of the genes to cause an antidepressant response. Some of the genes will be downregulated so that there is a decreased synthesis of the receptors. Some of the genes will be upregulated, resulting in an increased synthesis of critical proteins such as BDNF. Means signals an increase in BDNF release. The neurotrophic hypothesis of depression states that depression may be caused by decreased synthesis of proteins involved in neurogenesis and synaptic plasticity. We know that BDNF promotes growth and development of immature neurons. It enhances survival and function of adult neurons, and it helps to maintain synaptic connections. If the BDNF is low or decreases, this will result in cell atrophy and even cell loss. Monoamines can increase the availability of BDNF by starting a signal transduction cascade that causes the BDNF to be released. This slide is showing the suppression of BDNF production. On the right side, we see that with the growth of the BDNF is maintained, and so the neurons are strengthened and the connections are strengthened. On the left, we see that the genes for BDNF are turned off, and so there's a decrease in BDNF, which means there's a decrease of the ability of the brain to create neurons and their connections. And so the result is a loss of synapses or entire neurons by apoptosis. For BDNF, and therefore the BDNF will not be produced. And brain atrophy. Okay, this slide is talking about the 5 molecular targets of psychotropic drugs. And there's only a few major sites of action for all of our psychotropic drugs currently in use. About 1/3 of the drugs target one of the 12 transmembrane region transporters for a neurotransmitter. Another third target, the 7 transmembrane region receptors coupled to G proteins. The other sites of action for the remaining third of psychotropic drugs include enzymes, a 4 transmembrane region ligand-gated ion channel, and a 6 transmembrane region voltage-gated ion channel. Okay, so we've talked about neurotransmitters, neurons, theories of depression, targets of psychotropic medications, and now we will continue to talk about the actual medications, the SSRIs, the SNRIs, the atypicals, the tricyclic antidepressants, the MAOI antidepressants, and drugs used as augmenting agents. Available, and the abbreviations for them. We have SSRIs, selective serotonin reuptake inhibitors, and you see the list of those. The one that is not listed is fluvoxamine. The SPARI, that is given to one of the drugs called vilazodone, and it stands for a serotonin partial agonist and reuptake inhibitor. Serotonin partial agonist and reuptake inhibitor. And then SNRI, selective norepinephrine reuptake inhibitor. Actually, that should be serotonin norepinephrine reuptake inhibitors. There's a new one you can add to the list. It is levomilnacipran, also called Fatsima. The NDRI would be norepinephrine dopamine reuptake inhibitor, and that refers to bupropion. A norepinephrine reuptake inhibitor is atomoxetine. The NASSA stands for noradrenergic and specific serotonin agent, and that refers to mirtazapine. The SARI is a serotonin antagonist reuptake inhibitor, and that would be trazodone. TCAs are tricyclic antidepressants. MAOIs are monoamine oxidase inhibitors. And the last one is multimodal, and that refers to vortioxetine. And it's multimodal because it works by direct modulation of specific serotonin receptors. SSRIs and the SPARI listed here. This is a receptor overview of serotonin. So the presence or the absence of 5-HT at various receptors may lead to side effects. So 5-HT1A and B result in sexual dysfunction and GI problems. 5-HT1B, you can end up with erectile dysfunction. 5-HT2A and 2C, also sexual dysfunction. 5-HT3, GI problems and vomiting. 5-HT2A, problems with sleep. And 5-HT2C, problems with appetite. Details of the subtype receptors and their function. Okay, just to finish up about paroxetine, there's also the inhibition of NOS, which is nitric oxide synthetase. This can cause sexual dysfunction. There's also an effect on histamine, which can improve sleep and appetite. Standard dose of paroxetine is 20 to 60 milligrams, and it is a potent inhibitor of CYP2D6. There has been some research showing that this is the one SSRI which should be avoided in pregnancy. If used early in the first trimester, there's some research that showed there may be some heart defects, and used in late pregnancy can also cause respiratory problems. Okay, then sertraline is the slide we're on. We have SERT, serotonin transporter. We have DAT, and this can result in increased energy, motivation, and concentration. And we also have alpha-1 receptor binding, which can cause anxiolytic actions and can help with psychotic depression. Standard dose is 25 milligrams to 200 milligrams. Okay. Called enantiomers, which are mirror images of each other. There are right and left enantiomers. The right-sided has weak antihistaminic properties. The dose of citalopram is 20 to 40 milligrams. 60 milligrams has been identified as causing QT prolongation, and so should be not prescribed beyond 40 milligrams. Here we see the S enantiomer, which is the left-sided enantiomer, and this is S-citalopram or Lexapro. This drug has less side effects than citalopram, 10 to 20. Useful in treating OCD. There's also an alpha receptor involvement, which can decrease anxiety. And there's also the increased ability to control impulses. It's useful in psychotic depression. There's inhibition at CYP1A2 and CYP3A4. The dosage is usually 100 to 300 milligrams once a day. Lazodone is the SPARI, which is a serotonin partial agonist and reuptake inhibitor. We have the SERT. We have partial agonist at 5-HT1A. This drug should be taken with food to increase the bioavailability. The dosing is 10 to 40 milligrams. Half of the SERTs and half of the 5-HT1A receptors are occupied immediately. The blockade of the SERT causes the 5-HT to initially increase in the somatodendritic area of the serotonin neuron. And so this results in downregulation or desensitization of the somatodendritic 5-HT1A. Once the downregulation occurs, there's no longer inhibition of impulse flow in the 5-HT neurons, so the impulse flow is turned off. And so this results in more 5-HT being released in the axon terminal. The final step is the desensitization of the postsynaptic 5-HT receptors, and the dominance of the 5-HT1A actions may lead to downstream enhancement of dopamine release, which in turn may mitigate the sexual dysfunction. All right, so we're moving on now to SNRIs. The principles of action are the same as for 5-HT. So the SNRIs, we have venlafaxine, desvenlafaxine, Savella, which is milnacipran, and not listed here is levomilnacipran, and the NDRIs, which would be bupropion. With the SNRI and reuptake inhibition on the left slide and the norepinephrine reuptake inhibition on the right slide, both pumps are blocked, resulting in the antidepressant effect. Okay, so this is showing the norepinephrine transporter blockade and dopamine blockade in the prefrontal cortex. The prefrontal cortex has very few dopamine transporters or DATs. So dopamine can diffuse from the synapse and exert its actions within a larger radius. The dopamine actions are terminated at the norepinephrine axon terminals because dopamine is taken up by NET. There is NET blockade in the prefrontal cortex, and that results in an increase in synaptic norepinephrine. The norepinephrine transporter takes up dopamine as well as norepinephrine, and so the NET blockade also increases synaptic dopamine. So NET increases norepinephrine throughout the brain, and both norepinephrine and dopamine in the prefrontal cortex. Vaccine at low doses, they both have serotonergic actions. A higher dose is needed for the norepinephrine actions, and it needs to be at least 150 milligrams To actually get the dopamine benefit, the dose needs to be at 225 milligrams of venlafaxine. Venlafaxine is converted to the active metabolite desvenlafaxine by 2D6. But in desvenlafaxine, the norepinephrine reuptake inhibition actions are greater than for venlafaxine, and the SERT is more potent also. The dose of desvenlafaxine is 50 to 100. That's what has been approved by the FDA. However, Dr. Stahl notes that doses of up to 400 milligrams may be used in some cases. The main side effect to watch out for is hypertension, and so you would check blood pressure routinely. Venlafaxine is also or can be difficult to wean off of, and in those cases, you can supplement the person with some fluoxetine to make it easier for them to get off venlafaxine. SERT, the NET, it's also believed that it has norepinephrine actions that may be effective in decreasing pain. It is an inhibitor at 2D6. The dosing is from 20 milligrams to 120 milligrams. The NET can increase dopamine, so there may also be an increase in pleasure and less pain. Milnacipran is Savella. In this country, it is approved for use in treating pain or fibromyalgia. In Europe, milnacipran is approved for treating depression. It has SERT and a large effect, very strong NET inhibition, which may be what helps with pain. The dosing is 25 to 200 milligrams in divided doses twice a day. The enantiomer of milnacipran is levomilnacipran. Its brand name is Vetsima. It is approved in this country as an antidepressant, but it is approved in Europe as a drug for pain. So both of these drugs can be useful for both pain and depression. So mirtazapine is a noradrenergic and specific serotonin agent. There are no CYP450 conflicts, and so it is a good choice for people who are on a lot of different medications to avoid any interactions. It is most effective in low doses to improve sleep. So 7.5 milligrams to 15 milligrams may be used to help with sleep. It can be dosed up to 45 milligrams, but the effects on sleep will not likely be as good at the higher dose. This drug will also likely cause weight gain as it increases appetite. And it's useful for people who have lost a significant amount of weight due to depression. An SARI is a serotonin antagonist reuptake inhibitor. It's trazodone. It's not used as an antidepressant. It is used to help with sleep, typically 50 to 150 milligrams. It is off-label for sleep, but it has been used for that purpose for many years. Wellbutrin is a norepinephrine dopamine reuptake inhibitor. It comes in the SR dosing as well as the XL. It is contraindicated if there is a seizure history. It can cause or control cravings for food and smoking, and can be helpful for weight loss and can be helpful for ADHD. And it may help if there is sexual dysfunction from an SSRI or an SNRI. Alpha-2 antagonism, increasing norepinephrine release in the raphe and in the cortex. So neurotransmitters can interact with each other. The effects will be positive or negative depending on what neurotransmitter and where in the brain. An alpha-2 antagonist, such as mirtazapine, can increase norepinephrine release by binding to these receptors in the locus ceruleus and in the cortex. When mirtazapine blocks the autoreceptor, the neuron doesn't shut down the flow of norepinephrine and it continues to flow. This is showing how mirtazapine has alpha-2 antagonism, which increase serotonin and norepinephrine release in the cortex. So norepinephrine can then stimulate the alpha-1 receptors on the serotonin neuron. This results in serotonin release in the cortex. Its primary action is alpha-2 antagonism. It also blocks three 5-HT receptors, 2A, 2C, and 3, and it blocks histamine. It has a strong effect on sleep, increasing appetite and cravings due to the 5-HT2A and 2C receptors. The histamine receptor also results in increased sleepiness and weight gain. Trazodone is the SARI, a serotonin agonist reuptake inhibitor. It acts by a potent blockade of 5-HT2A and 2C and SERT. It also blocks the alpha-1 adrenergic receptors, and there is H1 receptor antagonism. A very high dose is required for an antidepressant effect. However, doses for sleep, 25 to 150, do not saturate the serotonin transporter. Okay, so tricyclic antidepressants, or TCAs, are very effective, but they have lots of side effects. Examples would be amitriptyline, nortriptyline. Both of those can be used for pain management or headaches. Doxepin is often used for GI issues. There's also a very low dose called Silanor. Another tricyclic antidepressant is clomipramine, and that's most often used to treat OCD. All of them block reuptake of norepinephrine. All of them are antagonists at H1, alpha-1, and the muscarinic cholinergic receptors. And all of them block voltage-sensitive sodium channels. Some are potent SRIs. Some may also be antagonists at 5-HT2A and 2C, resulting in sleepiness and weight gain. HT2A portion inserted into the 5-HT2A receptor, blocking it and causing an antidepressant effect and improving sleep. There can also be the tricyclic inserted at the 5-HT2C receptor, blocking it, causing an antidepressant effect. Also, the TCA with an antihistamine H1 portion inserted into a histamine receptor, causing the side effects of weight gain and drowsiness. There can also be the TCA with an anti-muscarinic portion inserted into an acetylcholine receptor, which can result in causing constipation, blurred vision, dry mouth, and drowsiness and urinary retention. Tricyclic antidepressants have a lot of side effects. A tricyclic medicine shown at the adrenergic portion inserted into an adrenergic receptor can cause dizziness, drowsiness, and decreased blood pressure. TCAs shown with a sodium channel blocker portion blocking voltage-sensitive sodium channels in the brain and heart. An overdose, therefore, can result in coma, seizures, arrhythmias, and death. TCAs are not just used as an antidepressant. Clomipramine is used for OCD, for anti-panic, and they are also used for neuropathic pain, headache, and low back pain. These days, the use in depression is second line. Okay, so to summarize, tricyclics are not used very often today for depression because of the side effect profile and the possible cardiac toxicity. They can be effective as a mild pain reliever. They can be helpful in GI problems, and they will also work as sleep agents in low doses. There's a version of doxepin called Silanor, which may be helpful for sleep. Okay. The MAOIs are monoamine oxidase inhibitors. They're not often used, but it's good to know what they are and what the precautions are. It metabolizes 5-HT, norepinephrine, and dopamine. That's left on the slide. The MAOB metabolizes dopamine, 5-HT, and norepinephrine only at high concentration. So the MAOA inhibition of 5-HT, norepinephrine, and dopamine, or rather the MAOA inhibition increases the 5-HT, norepinephrine, and dopamine. This also increases in dopamine, though not as much, because the MAOB continues to destroy the dopamine. Inhibition of MAOA is an effective antidepressant. MAOB inhibition increases dopamine to some extent, which can be therapeutic, particularly in something like Parkinson's. This shows a combination of combined inhibition of MAOA and MAOB. This can have a robust antidepressant effect due to an increase in 5-HT, norepinephrine, and dopamine. Tyramine which we find in cheese, increases the release of norepinephrine. Tyramine is present in foods, including aged cheeses. In normal circumstances, the MAOA readily destroys the excess norepinephrine released by tyramine, and then there's no problem. However, when MAOA inhibition is occurring in the presence of tyramine, this results in a large accumulation of norepinephrine, which can cause an excessive stimulation of the postsynaptic receptors. That in turn will cause vasoconstriction and an elevation in blood pressure. Transdermal selegiline, this is a selective MAO-B inhibitor, works only at high doses. If it were given orally, it would cause a tyramine reaction. But the transdermal administration delivers the drug directly into systemic circulation, and so the high dose goes to the brain but not to the liver. This is looking at the reversible inhibition of MAOA. What we see is a combination of an MAOA inhibitor and tyramine. However, here the MAO inhibitor is reversible type. And so it is RIMA, reversible inhibitor of MAOA. The accumulation of norepinephrine released by tyramine can displace the RIMA, allowing for normal destruction of the extra norepinephrine. And the blood pressure isn't affected adversely. People who are on MAOIs should avoid things like nasal decongestants. So combining these two drugs may be enough to cause increased blood pressure or a hypertensive crisis. And so SSRIs and MAOI should not be combined because there will be an interaction. So an inhibition of the serotonin transporter increases the synaptic availability of serotonin. The inhibition of an MAO also leads to increased serotonin levels. So combining those things can cause excessive stimulation of postsynaptic serotonin receptors, which can lead to hyperthermia, seizures, coma, cardiovascular collapse, or death. And so we need to know how to switch from an SSRI to an MAOI. There is a risk of serotonin toxicity, so complete washout of an SSRI is necessary before starting the MAOI. You need to wait at least 5 half-lives after stopping the SSRI before starting the MAOI. That usually takes 7 to 14 days. If the person is on fluoxetine, you need to wait 5 weeks. The opposite, switching from an MAOI to an SSRI, the guidelines state you wait 14 days. And then here are some guidelines that you can read over in using an MAOI. So a couple of things to remember. Using an MAOI is not something you will do as a new practitioner. But it can be a wonderful alternative when the drugs that are first line have not been effective. The dietary restrictions are not overwhelming for everyone. And the patch form, the selegiline NSAM, may be a good way to start using an MAOI. Okay, now we're going to talk some about augmenting and supplementing. So we're talking about the possibility of combining two different classes of antidepressants, or augmenting with an antipsychotic, or adding a supplement such as fish oil or vitamin D, SAMe, or L-methylfolate. L-methylfolate is necessary in stimulating neurotransmitter synthesis and decreasing the production of COMT, which results in an increase in dopamine. So, result in remission. So, the use of monotherapy is pretty much changing to use multiple pharmacological mechanisms with two or more therapeutic agents. It's recommended to start this earlier in treatment. Here we see some different combinations of meds. What we have here is an SSRI, an SNRI, rather an SSRI or an SNRI, plus an NDRI. So in the top one, we're combining an SSRI with Wellbutrin. In the bottom one, we're combining an SNRI with Wellbutrin. And we see here how the catecholamines can be boosted when the medicine is combined with Wellbutrin or bupropion. Pain. This is referred to as California rocket fuel. And in this, the serotonin is boosted. It's a quadruple boost. We've got reuptake blockade. We've got alpha-2 antagonism, 5-HT2A antagonism, 5-HT2C antagonism. Norepinephrine, there's also a quadruple boost with reuptake blockage, alpha-2 antagonism, 5-HT2A and 2C antagonism. And dopamine is double boosted with 5-HT2A and 5-HT2C antagonism. These are arousal combos. We have an SSRI with a stimulant. An SNRI with a stimulant, and or an SNRI with modafinil. Antidepressants and the FDA indications for these particular medications. Okay, so BH4 is a cofactor for neurotransmitter synthesis. So BH4 is critical enzyme cofactor for tyrosine, which is an enzyme for dopamine and norepinephrine synthesis. BH4 is a critical enzyme cofactor for tryptophan, which is an enzyme for 5-HT synthesis. regulates BH4 production and therefore plays an indirect role in regulating neurotransmitter synthesis. We know that if there is a folate deficiency, that can lead to decreased neurotransmitter levels, which can result in depression. So even if the person is on an SSRI, the serotonin levels remain low. A genetic test can be done to check for MTHFR deficiency. The L-methylfolate assists in termination of the BH4, which is a critical cofactor for synthesis of the neurotransmitter. The L-methylfolate can lead to methylation of the promoter for the gene of the enzyme COMT, which inactivates dopamine and norepinephrine. If the L-methylfolate is deficient, then BH4 is also deficient, and so not enough to activate the enzyme that synthesizes dopamine, and so dopamine levels are reduced. Without the L-methylfolate, methylation of the gene for COMT is reduced, and that results in activation of the gene and increase in COMT synthesis, which results in increased dopamine metabolism, which further reduces the levels of the dopamine. If the L-methylfolate is present, then there's an increase in BH4 production, and so an increase in dopamine. This results in a decreased synthesis of COMT, which decreases metabolism of dopamine, and so there is an increase in the presence of the dopamine. The effects of two or more risk genes working together to increase risk of an illness such as depression is called epistasis. A T variant of MTHFR conspires with a Val variant of COMT to reduce information processing in the DLPFC during a cognitive load in schizophrenia. The same genetic interaction may also be occurring in depression. Okay, so SSRIs in pregnancy and lactation, they are considered safe in pregnancy, although there's some question about paroxetine, and that's generally avoided. There can be a serotonin discontinuation syndrome in the newborn where they become irritable and cranky and cry a lot more. One needs to weigh the risk versus benefits, and we know that there are risks associated with untreated depression and anxiety during pregnancy, and so that needs to be considered. Children, adolescents, and the geriatric. There is a black box warning for all below the age of 25 in using a serotonin drug. The black box warning states that it is possible to have an increase in suicidal thinking when taking an SSRI. It is not a risk for an increased rate of suicide, but rather an increased rate of suicidal thoughts. And this is something you would make sure that your parents of your client are informed of this. The common side effects are listed here. And the serious ones as well. The most serious would be a serotonin syndrome. And these are the typical signs of excess serotonin. Someone who is diaphoresing with clonus and agitation is likely going through a serotonin syndrome. in determining what's going on, there would be a recent addition or an increase in a known serotonergic agent, absence of other possible etiologies, no recent addition or increase of an antipsychotic agent, and at least 3 of the following: agitation, myoclonus, hyperreflexia, diaphoresis, shivering, tremor, diarrhea, ataxia, or fever. There's also something called the serotonin discontinuation syndrome. In this, we have body symptoms like dizziness, nausea, vomiting, diarrhea, fatigue, lethargy, chills, headaches, sleep disturbances, as well as things like anxiety, restlessness, and irritability. All of these serotonin drugs need to be tapered gradually, except that you do not need to taper fluoxetine. Depression stands for Sequenced Treatment Alternatives to Relieve Depression. Ultimately, 66% achieved remission, but the odds of remission decreased with every trial, and the relapse time was 2.5 to 4.5 months. And so how long should you continue treatment? If it's a first episode, the guidelines are 6 months to a year. I encourage my patients to stay on for a year, hoping that during that time they will have learned some skills in dealing with depression and anxiety, and perhaps have made some healthier lifestyle choices as well. If the person has suffered a second episode and needed treatment again, the recommendation is to stay on the medication for 5 years. If they've had a third episode requiring treatment, then the recommendation is to stay on for a lifetime. It's important to check adherence. You may also want to do some gene testing to check for a slow or rapid metabolism or problems with a serotonin transporter gene, for example. So, things to keep in mind, some guidelines: treat symptoms, not DSM diagnoses. It is a process of trial, and everybody is different. Start low, go slow, but not too slow. Try to limit your changes to 1 at a time. Increase medicines first, augment second. Consider addition of L-methylfolate or Deplin. Change the medicine. Thirdly, wait. Possibly consider other non-medication interventions.